Guys, how are you?
Morning, good.
Moment, please. All right. Let's see here. We got Josie, Molly, Maya, you, Tarek, are still there. Is this your last meeting, Tarek? Your last
Yeah.
EP conference?
Yes.
Wow. Well, it's going to be very different without you, that's for sure.
Thanks.
Okay. So why don't we, maybe this is all we're going to see today. So, okay, you can see this area here, right? And I'm pointing to, it says EP conference and all.
Yes.
Okay. All righty. This is a tracing that was sent to me a few days ago from one of our former fellows who is now an attending physician in a different state in the United States. And this fellow was asked to comment on this tracing and to offer some possible remedies for it. So why don't we see Dr. Kalis, what do you think we're looking at here?
So the first thing that it looks like to me is torsades.
Mm-hmm.
So it looks like kind of VT that's, changing in morphology.
So what is torsade? What is the definition of torsade?
I guess it's like a type of VT that we usually see with like long QT syndrome.
That's
like,
right. That's
yeah.
right. Polymorphic VT in the setting of a long QT is the definition of torsade. Torsade, to point, I think in English, means twisting on the point. So the ECG looks like it's kind of twisting all over the place. Is this a narrow QRS tachycardia or a wide?
A wide QRS.
Is it regular or irregular?
I think it's irregular.
Yeah, it's quite irregular, right?
Yeah.
These our intervals are very different than these, right? Or these even. And is it regularly irregular or is it irregularly irregular?
I would say it is irregularly irregular, I think.
Okay. So when you see a wide QRS like this, that looks like this. So torsade is one possible cause. Is there anything else that this could be?
I guess with like a irregularly irregular tachycardia, whether it's like narrow or wide, I would think of AFIB.
So how could you make this tracing be AFib? I agree. Generally speaking, atrial fibrillation is an irregularly irregular rhythm.
If you have like pre-excited AFib, it could look wide complex.
Right. So this is a very classic example of somebody who has pre-excited AFib. Now it could be torsade. Usually when people have torsade, they have, not always, but they could have some breaks of sinus beats in there. Also, this much VT, if this were VT at this type of rate, you would think the patient would not remain in this for very long. In other words, you would expect it would progress to VF. And just the mere fact that they could get a 12-lead electrocardiogram means that somebody thought the kid looked well enough to do this. So yes, those are both the differentials. So what would you, if this were a WPW patient, is there anything we can say about the patient's WPW?
Yeah, that's a high risk.
And why do you say that?
Because it is conducting at a pretty high rate.
And that's true. What's the so-called line in the sand, if you want to think about it, where we start to believe that the risk of sudden death is higher?
I think it's like 200 milliseconds as a cycle length.
No, not quite.
Or
200.
250?
Well, okay, let me restate that. 200 definitely would be high risk. That's right. But actually, a longer cycle length also would be considered high risk. So
I think maybe 250.
yes, good second guess. So yes, so cycle length 250 would shorter than 250 is considered to be high risk, and that's based on a paper from 1979 in the New England Journal of Medicine by a guy named George Klein in Canada, in which they basically took a bunch of WPW patients who had arrested and didn't arrest, and they literally put them into AF. And these patients were adults and they were awake during their study. And they showed that patients who had conduction at cycle lengths shorter than 250 milliseconds were at higher risk for development of sudden cardiac death. So how do we test that in the lab? Let me go to Molly. Molly, so Maya just told us that the shortest RR of 250 or less is high risk. How do we test this in the cath lab if we have a patient who we think who has WPW and we're going to ablate them, but we want to know what the risk level is before we ablate them? How do we do that practically in the cath lab?
You would you rapid pace and decrease your cycle length, like starting at a higher number, like 600 or something, you start at a higher number, and then work your way down. And when you see it, you will see it convert. You can see it on the surface ECG leads if you're seeing evidence of preexcitation on there, convert once you get less than whatever that person's length is, convert to where it's now not evidence of preexcitation.
Okay, very good. So in other words, if I could just restate what you're saying, we pace the atrium faster and faster until we lose preexcitation, and that allows us to know what the shortest preexcited R-to-R interval is. And sometimes in the EP world, we call this the SPERI, or the shortest preexcited R-to-R interval. So that's what we do often as a surrogate for the rhythm that we are looking at on this electrocardiogram. Is there anything else that we could do to assess risk during the cath if we're cathing this patient or a patient with WPW? So that's the most common. You get 100% credit for that question, but if I wanted to look at other ways to assess the degree of risk of my patient, what else could I do? Well, one thing we could do is actually induce AFib, right?
Oh, yeah. And if
Sometimes we do that. We usually, most of the time we try. Let me ask you a better question. If we're going to ablate the patient anyway, why do we do this? Why induce AFib or rapid atrial pace? Why not just go ahead and ablate the darn thing? Why do we actually do this testing? Is it just to intellectually stimulate ourselves?
I'm guessing no.
Okay, that's good. Good guess.
I'm trying to think.
Well, it may not be intuitive, but the main reason that we do it is because we never know if we're going to be successful, right? We don't know whether we are successful 90 to 95% of the time when we ablate WPW in most cases, but we're not always successful. Just a few weeks ago, we had a failure. So that can happen. And so you kind of want to know what your patient's risk level is in the event that you're unable to make it go away. You'd want to know, what am I left with? And do I need to be worried about this patient or not? I think that would probably, in my view, be the most important reason. The other reason is, of course, if you have an asymptomatic patient, there's a lot of debate about this. In fact, I'm going to be in a debate on this very topic at the World Congress on whether or not asymptomatic WPW patients should be ablated, no matter what the characteristics of conduction of the accessory pathway are. And the rationale that people offer for doing that is that there are rare cases in the literature of people who have had formalized testing. They passed their testing, meaning that their shortest RR interval was not particularly short, and yet they still went on to have a cardiac arrest or something along those lines. But I think in the majority of cases, we would, in an asymptomatic patient, most people, I think today still, if the pathway was low risk, and low risk is usually defined as shortest RR interval that is longer than 300 milliseconds. In other words, conducting at a rate lower than 200 beats per minute. Most would consider that to be a so-called low-risk pathway. Then we would not necessarily ablate that patient. What we normally do, and I don't know if this is right, is we'll try to induce AFib or rapid atrial pace. And by the way, many young people, it's hard to induce AFib in, which is probably why it is that sudden cardiac death is not very common in WPW, because of course you have to have AFib in order to induce that. But anyways, we'll see what the conduction characteristics are. The other thing that I often tell patients is, if you are not high risk, but I am easily able to induce orthodromic reentrant tachycardia or ORT or SVT, then I would recommend that we go ahead and ablate it, since we are already there. And since it's likely that if I can induce it, that the patient will spontaneously have tachycardia at some point in the future. That's been our general approach. That said, there are many labs, I think, where they go in with the idea that they'll do all that testing to help inform how aggressive they want to be in terms of ablation, but they will not ablate unless, and then they will ablate accordingly. So for example, actually the first group I heard doing this was the Boston group. They presented an abstract probably a decade ago in which they showed that they basically ablated everybody, but their success rate for septal pathways, or meaning that they were close to the AV node, were actually lower. And the reason it was lower was not because of the location of the pathway in and of itself, but because of a lack of aggression on the part of the electrophysiologist in an asymptomatic patient who had a low risk pathway. So anyways, getting back to this case. So you're in the emergency room. What would you do at this point? Why don't we go back to Maya, since she was invested in this case. So Maya, you're on call, like your former ex-fellow was on call, and they show you this tracing. What are you going to recommend that they do? Maya, you still there? You guys, can you still hear me? Are we still on here?
I hear you. I don't hear Maya.
Oh, okay. So Molly, why don't you proceed?
Wow, Maya, leaving me out to dry.
Sorry, I was on the phone with the cath lab. What was that?
Oh, the old I was on the phone with the cath lab excuse. No, I was saying, Maya, okay, so we we think this is pre-excited AFib. It is possible that this could be torsade. What would you tell the emergency room to do? You're at home, you're finishing up the season of Curb Your Enthusiasm on the couch with your husband, and you see this tracing. And what are you going to tell the emergency room doctors as you're, getting dressed to go back into the hospital to see this patient? Are you going to tell them to wait until you get there? You live 45 minutes away. You're out in Westchester, and you're coming into Mount Sinai. And are you going to tell them just, hold the fort? I'll be in a little while. Don't do anything. Or would you ask them to do something?
I would probably ask them to do something rather than wait 45 minutes.
Okay. Good
and
thought.
I guess you could try doing a cardioversion.
Yeah, I think you would probably want to, probably the single best answer would be to cardiovert this patient. Of course, I remind you, we would sedate the patient. Do not do this awake in an awake person, ever. Even though this is an urgent / emergent situation, unless the patient is unconscious, you would get somebody to sedate this patient, and you would cardiovert them. And how much energy would you give them? I
would do 0.5 joules per kilo, I guess, to start.
On the theory that this is AFib, is that why you're doing that low of a dose?
Yeah, I think so. And then go up from there.
There's nothing wrong with that answer, but I think in general, when you're in an emergency, I probably wouldn't give less than 1.
Okay.
Just because you're not going to really know if it worked. I mean, it's sort of odd that I would recommend that, because I'm the co-author of a paper in which we showed that actually 0.4, I think, or 0.3 is effective in most patients, but per kilo. But no, we would usually give 1 per kilo if it's AFib. What if it were torsade? What would you give?
I guess then you probably do 2 joules per kilo.
That's right.
Okay.
So 2 joules per kilo would be a more appropriate dose for someone who's in ventricular arrhythmia. And so one could make an argument that if you're not able to determine from the tracing which of those it is, that 2 per kilo would be the better choice. So anyways, they gave that therapy, and this is what they found afterwards. This is the same patient. So what is the diagnosis, Dr. Kalis?
I mean, it looks like there's a WPW.
That's right. So patient has WPW. So this was, in retrospect, preexcited atrial fibrillation. Okay, so now the patient is waking up from their sedation and their cardioversion, and they are thanking you for saving their life. And so let me kick this over to Dr. Candon. So Tulsi, Maya says, listen, I really, there's one more episode to the season of Curb Your Enthusiasm. Would you mind just taking over this case now? I got to go. I really need to find out what happened to Larry David. You say, happy to help out, Maya. Good luck with that. She's told you the whole story. The patient is in the emergency room. 16-year-old says, boy, I feel so much better. Can I go home now? What do you, what is your plan at this point? Let's say it's 10:30 at night on Friday.
Yeah. I definitely would not send them home just because they've had the AFib required cardioversion. And I mean, like we just discussed a few minutes ago, this patient's going to need an EP study and probably ablation. So I would admit them, keep them NPO, and do an EP study. Maybe even do an echo prior to, like if they have, I guess if they have like undiagnosed WPW, I'd want to do an echo to make sure there aren't any structural abnormalities causing the WPW.
Or what is the most common congenital anomaly that's associated with WPW?
Honestly, I forget. Is it Epstein's?
So you did not forget, you remembered.
Right, okay.
Yes, Epstein's would be the number one, although this electrocardiogram would suggest that if it is Epstein's, it's a very mild form of Epstein's, right?
Right.
Because
There's no right atrial
it
enlargement.
doesn't seem like we have right atrial enlargement, and
Yeah.
it might even be, I'm not even sure the leads are on properly in this patient, but this patient clearly doesn't have right atrial enlargement. But you could have very mild Epstein's anomaly with very minimal displacement of the tricuspid valve.
Mhm.
But yeah, you would want to know that people who have LTGA can have a higher incidence of accessory pathways. This tracing and the forces does not suggest that, but certainly you would want to know. Okay, so you've done your echo. So you've kept the patient overnight. You've asked the fellow on call, Tarek, to do an echo. He's done the echo in the morning. He tells you it's normal.
Okay.
It's Saturday. So what do you want to do? Do you want to keep the patient in the hospital until Monday when either me or Barry can ablate the patient? Do you want to, is there any other options? Let's say for the sake of conversation that the cath lab has a very packed schedule. We have 3 harmony valves. We have the rep from Medtronic coming, then we have 14 biopsies after that. So it doesn't seem like we're going to be able to do it on Monday.
I mean, if they have a high risk, if they have a high risk pathway, then they, like we've discussed, they have a high risk of a sudden death, like AFib degenerating into ventricular fibrillation. I would keep them until it's
okay, so that's one option for sure. You get 100% credit for that answer. That's true. You could just keep them and say, well, this patient is staying until until there's a space in the lab to ablate. That's perfectly reasonable. What if the patient says, I don't want to have an ablation, but I don't also want to have a risk for dying suddenly? Is there an alternative approach?
Yeah, you could treat them. You can do outpatient treatment with, an extremely clear directions of how to get back or when to come back to the hospital. But yeah, you could do outpatient treatment.
So what medication, are there any medicines that could lengthen the effective refractory period of the pathway and reduce the risk for sudden death in this patient?
Could we do propranolol?
Propranolol does not in any meaningful way affect the pathway. It may reduce the chances of having fib. It may reduce the chances of having tachycardia, but not in a reliable enough way in somebody who has just demonstrated that really scary looking EKG that we would feel comfortable.
I know IV I would probably go.
Well, IV would only work while you have the IV in and the patient wants to go home, right? So so another option would be flecainide is sometimes used. Flecainide can have some direct impact on accessory pathway conduction. So that would be one option, would put the patient on flecainide. The traditional or the standard medical therapy for something like this would be procainamide. It's important to remember that catheter ablation has really only been around since the 1990s in kids. It's not like a 100-year, treatment. And so, people had this type of arrhythmia in the 1980s and the 1970s and, for the 1,000 years before. But so that, I wasn't a physician then, but my understanding is that what would typically happen if somebody came in with this is they would convert the patient. And then what they would often do, you don't really need to do an EP study, right? Because you're seeing RR intervals that are even shorter than 300 milliseconds. So we know this is a very high-risk patient. So what would they do for these patients, or 250 milliseconds, I should say? They would often put them on procainamide, and if the patient were to lose preexcitation on proc, that would be viewed as a good sign that the pathway was very sensitive to procainamide. And if they did not lose preexcitation, then I think they would cath the patient and test the pathway formally on the medication to confirm that the pathway was not conducting at a rate that was dangerous. And so this was very common. Now, the problem with procainamide is it has a short half-life, and the long-acting version is only comes in tablets large enough for adults. And so there's basically no equivalent. Like, I think in kids, small kids, Proc had to be given like every 4 to 6 hours. So it was a very hard medicine to administer. It also has a lot of side effects, a lot of GI side effects. It can cause a lupus-like condition with rash and basically mimicking all of the signs and symptoms of lupus. Could get joint pain, etc. So it was really not a great therapy. And so patients who either could not tolerate procainamide or in whom there was still concern about a risk for sudden death, or were having a tremendous amount of tachycardia, would be sent to the operating room for an intraoperative ablation of the tachycardia. And the way that they would do this is the surgeon would have this sterile glove that had electrodes. It would be like a glove, and each finger on the glove had a bipolar of electrodes. And essentially what they would do, from what I understand, is they would lay it on the tricuspid or the mitral annulus, and they would do a mini EP study with the chest open, and they would pace the ventricle, and they would look to see which of the fingers of the glove had the earliest electrogram in order to identify the general location of the pathway. And once they would have the general location, the surgeon would either take a cryo tool and freeze the area. And the cryo tool used by surgeons is a long linear catheter. So you can make like 6 centimeter or 5 centimeter long lesions, or the surgeon would go on bypass and literally divide the tissue over a broad area where the general area of the pathway was, and then sew it back together again. And this was, you didn't have to be very precise. You just had to get the general sense, because you would basically, the surgeon would make a very, very big lesion to successfully ablate it. So anyways, in this case, probably the best option would be to keep the patient and then proceed with an EP study and ablation. And I believe, according to the former fellow who used to work here, that the plan was to keep the patient in the hospital and until such time as they could do an ablation. That would probably be the safest and best option. This is another example here from our own stress lab from just a few weeks ago. So this is a 14-year-old who is asymptomatic and has preexcitation. So Tarek, why are we doing an exercise study in an asymptomatic 14-year-old with WPW?
So the goal would be to elicit the tachycardia and see if it's a high risk pathway or not. Okay,
so two issues. Tachycardia, usually when we're talking about it with WPW, we're talking about ORT. So the goal is not necessarily to induce ORT or SVT of a stress test in this, although that would be important information, right? If we saw that patients were having ORT with exertion. Really, the goal is to see if we lose preexcitation because of what we just talked about before, which is that if you can conduct it at cycle lengths less than 250 milliseconds, you are at high risk for sudden cardiac death. And so what we're hoping is that the patient will lose preexcitation at elevated sinus rates, and this would demonstrate that the patient is a low-risk patient. And so Dr. Arnon often chides me for sending patients for this because she appropriately recognizes the fact that it is very unusual to actually see a study in which somebody loses preexcitation, because They really, because the problem is, of course, that patients can usually only get their sinus rate up to about 180 to 190, maybe if you're lucky, a little more than 190. And what we know that if you lose preexcitation at 199, you are low risk, according to what we believe. But if you can't get your sinus rate above 190, then you would never know if you were low risk or high risk. And so the problem with the stress test is it's often inconclusive, but that, at least right now, still remains the recommendation of the American Heart Association and Heart Rhythm Society and ACC for an asymptomatic child with WPW. But the reason I'm showing you this one is Dr. Arnon very gleefully brought this in to show me that, in fact, in this rare case, we see that the patient did, in fact, lose preexcitation at an elevated sinus rate. I'll show you. This is the patient's tracing before, and this is 5 minutes into the test, and we see what we want to see is a clear and abrupt change from preexcited to non-preexcited. So according to those measures and those recommendations, we would say that this patient with WPW is not a high risk, is a low risk patient for WPW, for the risk of sudden cardiac death. This does not say anything about their risk for having ORT, but at the very least, we could say with a reasonable degree of confidence that this patient is at low risk for sudden cardiac death. Now, again, there are many who do not agree with that, who say, yes, the risk is lower on average in a patient like this, but it is not zero. And they'll point to a handful of papers where there are either case reports or, my former partner, Scott Seresnak, I think even wrote a paper showing that there's a small number of people who have intermittent preexcitation that are high risk. And we've talked about why it is that having intermittent preexcitation may not be low risk. But the bottom line is, I think in an asymptomatic WPW patient, if I saw this finding, I probably would be comfortable with not proceeding with any further invasive testing or procedures in the absence of symptoms. Any questions about that? All right, well, I think with that, we'll stop for today. Hope you found that somewhat helpful, and I will see you in sign out in just a little while. Have a great day, everybody.
Thank you.
Thank you.